Swayam Prabha. Digital India. Educated India.
Welcome. In today's session, we will look at carcinoma pancreas. So, carcinoma pancreas can be studied under the following headings: pancreatic intraepithelial neoplasm, which is the initial feature in the development of pancreatic carcinomas; the pathogenesis of pancreatic carcinomas, the epidemiology, the morphology, and finally the clinical features including lab diagnosis or laboratory diagnosis. Pancreatic carcinoma or pancreatic cancer, when we say, we relate specifically to pancreatic ductal adenocarcinoma, which is the most common type, and that arises from the exocrine part. So, pancreas, as we see in this picture, has both the exocrine and the endocrine part. Now, the exocrine part is seen to be indicated by the ducts as well as the acinar cells. Now, whenever we say pancreatic adenocarcinoma or pancreatic ductal adenocarcinoma, we mean the carcinoma arising from the pancreatic ducts. Now, this is also known in lay terms or layman's terms as pancreatic cancer. This accounts for a very high number of cancer related mortality rates. In USA, it is the third most common behind lung and colon. The 5-year survival rate in most patients is seen to be 10%. The precursor lesions in this is PANN, or otherwise expanded to form pancreatic intraepithelial neoplasm, and others precursors are seen for mucinous neoplasms, which include mucinous cystic neoplasm and intraductal papillary mucinous neoplasm. Now, of importance in carcinoma pancreas or adenocarcinoma pancreas is PANN or pancreatic intraepithelial neoplasm. Now, the importance of this is that it is seen that in most of the patients with pancreatic ductal adenocarcinoma, adjacent to that there is a high grade PANN present. Moreover, the studies in animals also have pointed out to the fact that high grade PANN can proceed to invasive carcinomas, and the genetic abnormalities that are associated with PANN are also found in invasive pancreatic carcinomas. The genetic abnormalities are similar, as I said, and the most important one which is seen in PANN, the initial aspect of PANN is telomere shortening. Now, this is a picture depicting the progress of the neoplasm and the genetic abnormalities seen from PANN to invasive carcinoma. So, in PANN we get telomere shortening, then activating KRAS mutations. Now, this causes the low grade PANN to proceed to high grade along with the inactivation of CDKN2A. Now, high grade PANN, there will be mutations of TP53, SMAD4 and BRCA2, either mutations or deletions. Basically, there will be abnormalities in these genes, and as a result of that, the high grade PANN will proceed to an invasive adenocarcinoma. So, what exactly is PANN? PANN or pancreatic intraepithelial neoplasm is a well defined lesion which is non-invasive and starts from the small ducts, therefore, it is microscopic lesion. There are two types, low grade and high grade. So, initially whenever there is a telomere shortening, it becomes a low grade PANN. This telomere shortening causes the epithelial cells to become susceptible to further mutations and epigenetic alterations, etc., and therefore, these mutations will accumulate, giving rise to high grade PANN and subsequently to neoplasm or invasive neoplasm. Okay, this is a histopathological picture of pancreatic intraepithelial neoplasm depicting an enlarged duct with multiple papillary projections showing an isonucleosis and high grade features. So, the pathogenesis of pancreatic carcinoma involves multiple genes. It is not just a single gene that causes the malignancy, but it is a multi-step progression, and these involve usually somatic mutations and epigenetic silencing of the oncogenes, the tumor suppressor genes, and of course, DNA methylation. So, this picture which we have noted earlier also, we can make out low grade pannin with telomere shortening activating KRAS mutations as the initial genetic abnormalities, followed by inactivation of CDKN2A. Then the high grade malignancy, before it proceeds to invasive carcinoma, we get inactivation of TP53, SMAD4 and BRCA2 in predisposed individuals. So, telomere shortening is characteristic of pannin. The most frequently observed genetic mutations, accounting for up to 90 to 95% of the cases, is KRAS mutation involving the chromosome 12p. Now, KRAS is a small enzyme which is responsible for transporting signals from the receptors downstream and activating MAPK as well as P13 AKT pathways, and thereby it is the signal is transferred to the nucleus. So, what happens is this has intrinsic tyrosine kinase activity also. So, whenever it is enhanced, this causes an increase in cell proliferation. It induces the cell to go on proliferating. The next step in this genetic abnormalities noted in pancreatic cancer is inactivation of the tumor suppressor genes, prime among them being CDKN2, which is located on chromosome 9p. It accounts for approximately 30% of mutational changes which are noted. CDKN2 encodes for two genes which are very important for cell proliferation, and that is P16-INK4A, that is an inhibitor for cyclin dependent kinases, and the other is ARF, which augments P53. The next gene of importance is SMAD4, located on chromosome 18q, and this is seen to be abnormal in 55% of the cases. SMAD4 also is known as depleted in pancreatic cancer 4, and this is usually used for detection of pancreatic carcinomas. Signal transduction occurs from TGF beta receptors, that is how it performs its action normally. Now, the next gene is TP53, located on chromosome 17p. It is deleted or inactivated in 70 to 75% of the cases, and this results in the cell not undergoing apoptosis even if it is abnormal or there are accumulations of abnormal mutations. So, the cell growth continues. Now, all these genes together are responsible for varying degrees of cell proliferations seen in pancreatic carcinomas. So, other changes that are seen are epigenetic changes involving DNA methylation. There can be hypermethylation or hypomethylation. Hypermethylation usually causes CDKN2 silencing, and hypomethylation causes GATA6 as well as BRD4 overexpression in these tumors. Now, gene expression profile studies carried out have resulted in two prognostically important subtypes, and these are the classical ones with good prognosis and the basal like tumors with unfavorable or aggressive prognosis. So, most of these cases occur in the age group of 60 to 80 years, and certain groups are found to have a predilection for development of pancreatic carcinomas, and these include the African Americans, Ashkenazi Jews, the Japanese Americans and the native Hawaiians. In some patients, familial tendency has also been seen. This accounts for 10% of the carcinomas of pancreas, and this is associated with the germline mutation in cancer predisposing gene, especially BRCA2. The others involved include BRCA1, PALB2, ATM. So, they are looking for targeted therapy for patients affected with these cancers or patients having these germline mutations. So, environmental factors also play a big role, especially cigarette smoking, which doubles the risk of pancreatic carcinoma of the ductal adenocarcinoma type, and a diet rich in saturated fats. Now, chronic pancreatitis, because of the constant repair changes that occur in such cases, also predisposes to mutational changes and therefore to invasive carcinomas. Diabetes mellitus, it predisposes to pancreatic carcinoma. At the same time, in sometimes development of diabetes mellitus may be the first sign of an existing pancreatic carcinoma in the patient. Visceral obesity and smoking are also associated with an enhanced risk for development of pancreatic cancer. There are several associated syndromes, prime among them being Peutz-Jeghers syndrome, hereditary pancreatitis associated with PRSS1 and SPINK1. Peutz-Jeghers is seen with STK11. Then the FAM syndrome, that is familial atypical mole melanoma syndrome associated with CDKN2A. Hereditary breast and ovarian cancer, that is BRCA1 and 2, PALB2 and ATM as specified earlier. And lastly, HNPCC, that is hereditary non-polyposis colorectal cancer syndrome, in which MLH1, MSH2 and PMS2 are responsible, and right now they are looking for immune checkpoint inhibition therapy in these patients. So, moving on to the morphology, let us have a look at the specimen grossly of ductal adenocarcinoma pancreas. So, grossly it usually involves the head, about 60% of them, then body and tail account for 15 and 5% respectively. Rarely, in 20% of the cases, it can be diffuse or multiple. It invades peripancreatic tissue and has intense desmoplasia. This intense desmoplasia is responsible for it to have a hard and a grey appearance. It is usually stellate and poorly defined margins. So, the margins cannot be well defined. It is seen in the picture here, and this is the duct and this is the body of the pancreas. So, this here is the head of the pancreas with the tumor. This side is your mucosa of the duodenum. Because it involves the head of the pancreas, we know that the bile duct passes through that. So, as a result, it may give rise to distal bile duct obstruction. Microscopically, this lesion is characterized by a high degree of invasion and intense desmoplasia. The desmoplasia is quite a lot, and in fact, whenever a biopsy is taken, sometimes it becomes very difficult to distinguish whether it is a well differentiated ductal adenocarcinoma with dysplasia and inflammation, or it is a case of chronic pancreatitis with repair atypia. The adenocarcinoma seen can be well, moderately or poorly differentiated and accordingly graded as G1, G2 and G3, and it is composed of tubules, nests and irregular glands lined by malignant cuboidal to columnar cells showing varying degrees of atypia depending on the grade, that is G1 to G3. Mucin is one characteristic feature of pancreatic ductal adenocarcinoma. It is seen in most of the cases. Now, besides these cases, that is the classical, this is the classical type, there are variants too, like signet ring cell, colloid, medullary type, hepatoid, large cell with rhabdoid, adenosquamous, undifferentiated and undifferentiated with osteoclastic giant cells. So, clinically it is silent until invasion of the adjacent structures occurs. It can be associated with your symptoms secondary to the invasion of the adjacent structures, including pain, then obstructive jaundice because of obstruction of the bile duct there, and this can give rise to Courvoisier's sign, which is characterized by mild jaundice and a painless enlargement of the gallbladder. Another sign secondary to necrosis seen in pancreatic carcinomas, the necrotic components can give rise to your activation of platelets because of release of platelet activating factor and procoagulants, and this may result in migratory thrombophlebitis. This is also known as Trosser's sign and is seen in 10% of the cases. This was discovered by Armand Trosser, who also had the malignancy and therefore discovered this sign in himself. The usual presentation of pancreatic ductal adenocarcinoma is at an advanced stage, and these patients present with weight loss, malaise, anorexia, weakness, that is the cachectic symptoms usually seen with all cases of malignancy. The progression within the pancreas, there can be perineural and vascular invasion, and then from there it can go into the retroperitoneum. Direct invasion involves the stomach, the spleen, the adrenals and the transverse colon. The nodes usually involved are the peripancreatic, followed by the gastric, mesenteric, omental and portohepatic. Distant metastasis can be to the lung and the liver. Recently, these patients are being detected in early stages and hence can survive beyond 5 years too. Whereas most patients, that is 80% of the cases, are unresectable at presentation with extensive metastasis or local invasion, etc., and the survival is dismal in these patients. Staging of resected specimens follows the American Joint Committee on Cancer 8th edition system of PTNM, in which we grade the tumor size into PTIS to 4, IS is for in situ. PT1 is divided into 1A, 1B and 1C. If it is less than 0.5 centimeters, it is PT1A, and PT1B is 0.5 to 1 centimeters, and PT1C is 1 to 2 centimeters. PT2 is greater than 2 up to 4 centimeters, and greater than 4 centimeters is PT3, and involvement of the celiac axis or mesenteric artery automatically upstages it to PT4. Now, N0 is when there are no nodal involvement, and N1 is 1 to 3 regional lymph nodes, that is ipsilateral, and N2 is 4 plus lymph nodes. Early detection has been attempted by imaging involving ultrasonography as well as computerized tomography. Elevated serum CA 19-9 and CEA are seen more often in pancreatic carcinomas. CA 19-9, also known as carbohydrate antigen 19-9, is Lewis blood group antigen and is thought to be specific for pancreatic carcinomas, can be used for detection. However, it is not been used in a widespread manner to avoid any false positive results. CEA or carcinoembryonic antigen is used both prognostically and for detection. So, elevated levels of this are seen in pancreatic carcinoma, and it can be used to monitor the effects of therapy as well as post resection. So, this concludes pancreatic carcinoma and its morphology as well as its precursor lesions, its epidemiology and the clinical features. So, to summarize, carcinoma pancreas is one of the leading causes of cancer related mortality. The precursor is pancreatic intraepithelial neoplasm or PANN. Genetic aberrations include KRAS, which is the most important, accounting for 90% of the cases, CDKN2, SMAD4, which is most specific for pancreatic cancer, TP53. Aggressive subtype is the basal-like. Associated risk factors include cigarette smoking, obesity, diabetes mellitus and familial syndromes. The common site is head of pancreas, accounting for about 60% of the cases, wherein it presents as a hard irregular mass due to the extensive dysplasia seen, and it is usually a ductal type of adenocarcinoma. Presentation is with abdominal pain, or these patients may even present in an advanced stage with jaundice and obstructive symptoms, weight loss and thrombosis. The spread is to the retroperitoneum, adjacent organs, lymphatics and vascular. So, we come to the end of this session. Thank you for a patient hearing.